So here we have test question. Pause the video, take a few minutes, read this test, guess which answer is correct, and after let's discuss this test step by step. So it's 60-year-old woman with a history of alcohol use disorder, which immediately raises the question about alcohol-related liver disorder. And if we take into the account her age, years of alcohol abuse could cause cirrhosis. And as we see, she drinks 5 to 6 beers daily for the past 20 years, which is significant. So cirrhosis here is a real possibility. She complains on fatigue, abdominal swelling, and lower extremity edema. Fatigue is a non-specific sign. Abdominal swelling tells us about ascites, and we know that ascites develops due to the increase in hydrostatic pressure, or decrease in oncotic pressure, or increased permeability. Lower extremity edema also develops due to the increase in hydrostatic pressure, or decrease in oncotic pressure. On physical examination, she has ascites, which we already know. But in addition to this, she has palmarythema and spider angiomata, which are important clinical symptoms because both of them tell us about high level of free estrogens. This happens in pregnancy, but also it can be a sign of cirrhosis due to the decrease in sex hormone binding globulin level. In this case, it's 60-year-old woman, so definitely she is not pregnant. And due to the history of alcohol abuse, we can suspect that she has cirrhosis. After this, we look at blood analysis. Her hemoglobin is 105, which is low. Decrease in hemoglobin we call anemia. Also, she has decrease in platelet count, so she also has thrombocytopenia, which is also a sign of liver injury. The reason is that liver is a major source of thrombopoietin, which is a cytokine that stimulates production of platelets. With liver injury, thrombopoietin production decrease, which results in decrease in platelet production with development of thrombocytopenia. Creatinine in this case is normal, but if it was elevated in patient with cirrhosis, it would tell us about possible hepatorenal syndrome. Albumin level is decreased, and total bilirubin level is high. Because albumin is a major component of oncotic pressure, decrease in albumin level causes decrease in oncotic pressure, which results in ascites and lower extremity edema. So now we have explanation why they develop. So in addition to thrombopoietin, liver also produce proteins, as albumin, which provide oncotic pressure. Also, liver provides conjugation of bilirubin. Liver makes from unconjugated bilirubin conjugated bilirubin, which is water-soluble. And because it's water-soluble, we can excrete it into the urine or bile. So, with liver injury, albumin's production decrease, which causes decrease in oncotic pressure. And decrease in oncotic pressure causes development of edema and ascites. Also, with liver injury, bilirubin conjugation decrease, which results in increase in bilirubin level. And increase in bilirubin causes jaundice and scleral icterus. Why international normalized ratio is prolonged? The reason is that liver also produces coagulation factors, which provide secondary hemostasis. And we assess the effectiveness of secondary hemostasis by prothrombin time, partial thromboplastin time, and international normalized ratio. As we see, patient also has mild elevation of liver enzymes. Recall that in practically every liver disorder, the elevation of ALT prevails over elevation of AST, with just one exception. The increase in AST is higher than increase in ALT in case of alcohol abuse, because alcohol causes deficiency of pyridoxal phosphate, which is a cofactor of ALT, which is exactly the case in this patient. The second question is that why it's mild elevation, because obviously patient has severe liver damage based on her clinical symptoms. To explain this, let's assume that it's liver tissue, and liver tissue consists of hepatocytes, and hepatocytes inside them have liver enzymes. If it's acute damage due to the alcohol intoxication, for example, it causes damage to hepatocytes. With damage, hepatocytes die, and the content inside them release into the blood, including liver enzymes. As a result, the level of ALT and AST significantly increase. But in case of chronic liver damage that causes cirrhosis, some amount of hepatocytes is replaced by fibrous tissue, and the difference is that fibrous tissue do not have any enzymes. So in this case, the elevation of liver enzymes will be mild, simply because with decreasing amount of cells, the release of liver enzymes in response to injury decrease. That's why in this case, the elevation of AST and ALT is mild. So at this point, we are certain that patient has cirrhosis, and with cirrhosis, we always have to keep in mind portal hypertension. Excessive deposition of fibrous tissue in cirrhosis compress liver sinusoids, which leads to accumulation of blood in portal vein with development of portal hypertension. And we know that portal hypertension leads to formation of esophageal varices, hemorrhoids, and caput medusa. Among all cirrhosis manifestations, esophageal varices are by far the most dangerous one. The reason is that at some point, esophageal varices can become so overdistended that they can rupture, which will cause severe bleeding. And bleeding from esophageal varices has very high mortality rate. So our primary goal in any patient is to prevent life-threatening conditions. In case of cirrhosis, the most life-threatening condition is rupture of esophageal varices. And because of this, we always do upper GI endoscopy in any patient with suspected cirrhosis. Because with upper GI endoscopy, we can assess the extent of variceal distension and thereby the risk of rupture. Also, we have to know that for prophylaxis of esophageal variceal rupture, we use non-selective beta blockers, and in case of variceal bleeding, we use octreotide. Lactulose will be the first-line treatment of hepatic encephalopathy, and alpha-1 antitrypsin level we determine in case of suspected alpha-1 antitrypsin deficiency, which by the way can also cause cirrhosis. But in case of alpha-1 antitrypsin deficiency, patients have cirrhosis simultaneously with severe emphysema. In this case, emphysema is absent.